Hello there, my highly esteemed and valued and treasured viewers and listeners, and welcome back to our pharmacotherapy series. Welcome to part 12 of the series. My name is Dr. Nath Arwa, and I'm the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for those in the health sector. We are the virtual clinical pharmacy institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. Now, we seek to remain your premier source of crucial tips for high impact pharmacotherapy services. So I would like to urge you to sit back and spare me part of your precious time to share some tips with you. So in our first case, LKI is a 93-year-old geriatric patient, a lady to be specific, with COPD, chronic obstructive pulmonary disease, who is admitted to your hospital with influenza that is confirmed through rapid tests by your lab. And she rapidly becomes hemodynamically unstable. You intubate her and transfer her to your medical ICU due to the failure to oxygenate. She is desaturating at the moment. You retreat her with oseltamivir for 4 days. On day 4, LKI's vasopressor requirements begin to decrease. She's improving, thank God. And your clinical team initiate ventilator weaning trial. On day 5, her oxygen requirements increase and the pressure support for the ventilator is resumed. She is started on maximum norepinephrine doses. BAL, bronchoalveolar lavage culture, reveals the presence of gram-negative rods, and she is clinically diagnosed with pneumonia. Which of the following types of pneumonia does LKI have? Is it a VAP, a CAP, a HAP, or an HCAP? I'll give you 10 seconds to choose the correct option. So in my opinion, it's a ventilator-associated pneumonia. Answer A is correct. She develops this pneumonia more than 48 to 72 hours after endotracheal intubation was done. So that qualifies it to be a VAP. Answer B, in my opinion, is incorrect. It is a diagnosis of exclusion. Now, answer C, in my opinion, is not correct, because a VAP diagnosis takes precedence over HAP when the pneumonia develops more than 48 hours after mechanical ventilation is initiated. And answer D, in my opinion, is incorrect. This is not HCAP. HCAP is no longer a term recognized by the IDSA of the American Thoracic Society. In past guidelines, a VAP diagnosis took precedence over HCAP when the pneumonia developed more than 48 hours after mechanical ventilation. So let's move to the next question. Your infectious disease team chooses vancomycin as directed therapy for a patient with culture-proven methicillin-resistant Staphylococcus aureus pneumonia. Now, which of the strategies below is guideline appropriate for this patient? Is it achieving peak plasma vancomycin concentration for at least 50 milligrams per liter 1 hour after administering the dose? Is it employing a dosage regimen that allows the free drug concentration to exceed the MIC for at least 40% of the dosing interval? Or is it maintaining trough plasma vancomycin concentrations of 15 to 20 milligrams per liter? Or is it D, maintaining an area under the curve of 400 to 600 milligrams per liter? So I'll give you 10 seconds to make the correct choice. So in my opinion, D is the correct answer. Now, answer A, in my opinion, is incorrect. Currently, monitoring peak plasma concentrations has not shown utility in improving efficacy for pneumonia or for decreasing toxicity in this category of patients. Now, answer B looks incorrect to me. Vancomycin efficacy for treating MRSA pneumonia has been linked most closely to the pharmacodynamic parameter of area under the concentration curve. So maintaining plasma concentrations of vancomycin that exceed the MIC 40% of the dosing interval hasn't been shown to improve safety or efficacy for the treatment of MRSA pneumonia. Now, answer C appears incorrect to me as well. Maintaining trough plasma concentrations of vancomycin in the range of 15 to 20 was previously recommended in older national guidelines across the world for several types of infections like pneumonia, like meningitis. But of note, these recommendations were largely based on expert opinion, not on any randomized controlled trials. Now, D is correct. Maintaining that AUC range is recommended for serious MRSA pneumonias according to the newest vancomycin guidelines that are widely disseminated as we speak. So D is the correct answer. Let's move to the next question, which reads: a patient receiving empiric treatment for nosocomial pneumonia, HAP, experiences hive-like reaction to piperacillin tazobactam on the first day of therapy. Now, which of the following antibiotics would be considered appropriate IV therapy to substitute piperacillin tazobactam therapy to avoid cross hypersensitivity? Would you infuse dalbavancin, ciprofloxacin, ceftazidime avibactam, or ceftaroline? I'll give you 10 seconds to choose the correct answer. So personally, I would go for option B. Now, answer A is incorrect. It doesn't provide gram-negative coverage needed for patients with HAP, so it would lead to treatment failure. Option C is incorrect. Ceftazidime avibactam exhibits meaningful cross-reactivity with penicillin, so the same hives would likely occur. It shouldn't be used in this patient. Now, answer B is the correct option in my opinion, because it isn't known to have direct cross-sensitivity with any beta-lactam antibiotics. And I would just like to comment that aztreonam would also be an acceptable choice because it has very low cross-reactivity in patients with type 1 mediated allergic reactions to penicillins. Now, utilization of carbapenems, including their prior desensitization, may be necessary in specific situations like when the strain of bacteria is resistant to ciprofloxacin or aztreonam. And answer D is wrong in my opinion, because ceftaroline lacks activity against gram-negative pathogens in patients with HAP. It is important for this patient. So it's inappropriate for this patient. So it's important to remember that it does not cover the likely pathogens. It lacks activity against beta-lactamases as well. So it would not be effective if an enterobacteriaceae, for example, was the causative agent, and it has limited anti-pseudomonal coverage. And it still may cause Crohn's sensitivity with penicillins, and it can easily cause the type 1 hypersensitivity reaction, although data to that effect is limited. So I would be very reluctant to switch to ceftaroline. In my opinion, D is the wrong choice. Let's move to the next question. Your infectious disease team takes over the management of a patient by the name ZBP who has developed a nosocomial pneumonia and is becoming hemodynamically unstable. His current blood pressure is 80/50, well below the normal hypertensive set. Remember, before admission he was hypertensive and his pressure was averaging 140/95, and he weighs 95 kilos. So what would be the first choice of IV fluid for fluid resuscitation in ZBB? Would it be a liter of normal saline, 2 liters of 20% albumin, 3 liters of Ringer's lactate, or vasopressin administered at a dose of 0.03 units per minute? I'll give you 10 seconds to choose the correct option. So in my opinion, C is the correct answer. Now answer A is incorrect. Giving a liter of normal saline is not appropriate. This volume is insufficient according to the surviving sepsis guideline. The surviving sepsis campaign guideline, which recommends we resuscitate at a dose of around 30 ml per kilo per hour. That would bring us to around 2,850 for this patient, which can be rounded up to 3 liters because he weighs 95 kilos. So as an initial fluid challenge, this patient has severe sepsis or septic shock. A liter would be inadequate. Now, emerging data suggests that balanced crystalloids such as Ringer's lactate may be more effective and less toxic than normal saline. However, crystalloids such as normal saline are preferred over colloid therapy, just like the albumin in answer B, and that makes B incorrect. Albumin isn't the first-line therapy for patients with severe sepsis or septic shock. It is a grade 2C recommendation in the Surviving Sepsis Campaign International Guidelines for the management of severe sepsis and septic shock only after crystalloids have proven insufficient. Before the crystalloids fail, they don't recommend you start on the albumin. So B would not be the correct answer. Now answer C is correct in my opinion. It is backed by literature. It is a recommendation in the Surviving Sepsis Campaign International Guidelines for the management of severe sepsis and septic shock for initial fluid resuscitation in patients like ours here. Emerging data suggests that such fluids may prevent nephrotoxicity more effectively than normal saline. Answer D, in my opinion, is incorrect. It can only be added to norepinephrine to increase the mean arterial pressure or to decrease the noradrenaline dose. Now, because we haven't yet introduced any norepi for this patient, I would not recommend administering vasopressin at this stage. It's inappropriate. So in your new appointment at a university hospital, you encounter a patient who is being effectively treated for HAP caused by Pseudomonas aeruginosa. Now the organism was recovered from his via bronchoalveolar lavage and is susceptible to ceftazidime that has been used in the treatment. The patient has completed 5 days of IV therapy, thank God, and the admitting physician, who is not a member of your ID team, asks if the treatment of his private patient can be discontinued now. He is in a hurry to discharge. What, in your opinion, is the most appropriate duration of therapy for this patient? Would it be 5 days of therapy is sufficient, or would you insist on a 7-day course, or would you suggest a 14-day course, or would you advise him to continue treatment until radiographic results have returned to normal? I'll give you 10 seconds to make the correct choice. So in my opinion, 7 days would be ideal. I would insist the patient continues therapy for 2 more days. Answer A, which reads 5 days, is incorrect. In my opinion, it is not considered long enough by any guideline for the treatment of HAP of any etiology. It is premature to stop therapy in this patient after 5 days despite the favorable response. Answer B is correct. A 7-day course of antibiotics is warranted in patients with HAP who have responded well to initial therapy based on results of the studies by Chastre et al. And basing on IDSA and ATS guidelines. So I would settle for answer B. Now answer C, 14 days of therapy is now considered inappropriate. It's inappropriately too long to manage HAP patients for 2 weeks unless patients don't respond clinically, and depending on the rate of improvement in clinical, radiological, and laboratory parameters, you can make this choice. Now 14 days of treatment are not needed in our case here because we are seeing marked progress. Now D is wrong. Evidence of improvement using radiology is known to lag behind clinical improvement in patients with HAP. So according to treatment guidelines for pneumonia, antibiotic therapy should be discontinued when the patient is clinically stable, without waiting for the radiology results to be perfect. Yeah, we don't have to wait for those infiltrates to clear to stop therapy. Let's move to the next question. TNA is a female patient with type 2 diabetes mellitus and also has an acute kidney injury and was admitted to your hospital's general medical ward because she developed diabetic ketoacidosis and her blood glucose concentrations have stabilized, but her pulse oximetry is still at 89. TNA has rales and crackles in the right lower lobe, and the chest x-ray confirms the presence of a pneumonia. Sputum samples have been obtained and are being processed by your efficient lab, and she hasn't received any antibiotics within the past 150 days. She is hemodynamically stable at the moment, and the prevalence of MRSA at your hospital is 8%, and your lab tells you that piperacillin tazobactam covers 92% of all local gram-negative respiratory pathogens in your institution. So which of the following antibiotics would provide the most narrow antimicrobial spectrum of activity that is considered appropriate to use empirically in the management of pneumonia in TNA's case? Would it be piperacillin tazobactam alone, or would you administer piperacillin tazobactam over 4 hours by extended infusion with gentamicin, or would you administer 4.5 grams of piperacillin tazobactam over 4 hours alongside vancomycin infused over an hour, or would you administer piperacillin tazobactam alongside vancomycin and gentamicin? I'll give you 10 seconds to make the correct choice. So, in my opinion, A is the correct answer. Now, it provides the narrowest antimicrobial spectrum of activity that is guideline supported. It will provide coverage for the most gram-negative respiratory pathogens in that institution, as well as MSSA. Remember, we have very few incidences of MRSA in this institution. Now, the addition of gentamicin isn't needed because the resistance to the gram-negative bacteria in this institution is less than 10%. Now, the addition of vancomycin, which provides MRSA coverage, isn't needed because she hasn't received any antibiotics in the past 90 days, and the local prevalence in that institution is below the 20% mark. Now, the patient here is hemodynamically stable, so she's not in septic shock at all, and she's not mechanically ventilated either. So she isn't at an increased risk of MRSA pneumonia, in my opinion. Now, the addition of other agents such as vanco and gentamicin could further complicate the acute kidney injury that she's being managed for without providing additional benefits. That makes answers B, C, and D wrong in my opinion. Let's move to the next question. So, 2 days ago, your infectious disease team empirically initiated a male patient on IV levofloxacin, gentamicin, and vancomycin for nosocomial pneumonia that resulted in hemodynamic instability. Today, the culture results of deep sputum samples obtained 2 days ago in this patient demonstrate the presence of E. coli isolates that are susceptible to levofloxacin and to ampicillin. The patient is now hemodynamically stable, making good progress, although he requires 2 liters per minute of oxygen to maintain saturations above the 92% mark. He meets the criteria for your IV to oral medication switch program in your hospital. So, which of the following represents the next best course of action for this patient today? Would you continue IV levofloxacin, gentamicin, and vancomycin to complete the 7-day antibiotic therapy? Would you discontinue gentamicin and vancomycin, and change IV levofloxacin to oral levofloxacin to complete the 7 days of antibiotic therapy? Or C, would you discontinue vancomycin and continue IV levofloxacin alongside gentamicin to complete the 7-day antibiotic therapy? Or finally, D, would you discontinue levofloxacin, gentamicin, and vancomycin and initiate oral ampicillin to complete 7 days of antibiotic therapy? I'll give you 10 seconds to choose. So I would settle for option B. Now, in my opinion, answer A is incorrect. The current surviving sepsis campaign and IDSA guidelines for the management of HAP and VAP recommend de-escalation of antibiotic therapy to a single highly effective active agent based on the results of culture and susceptibility tests. Therefore, continuing IV levofloxacin, Genta, and Vanco would be inappropriate from an AMS point of view. Discontinuing gentamicin and vancomycin and continuing therapy with an antibiotic that is effective for treating the pneumonia and active against the isolated pathogens is the most appropriate course of action, which would make choice B appropriate. And that makes choices A, C, and D wrong in my opinion. Now, oral levofloxacin is indicated for treatment of pneumonia because of its high bioavailability, and it penetrates into respiratory epithelial lining and fluid to large extents. And these are the sites of action for the treatment of extracellular bacterial pneumonia. Now, whether to use combination antibiotic therapy for infection caused by Pseudomonas aeruginosa remains controversial. But the issue is clearer when it comes to the Enterobacteriaceae like E. coli, where the use of combination therapy is likely to contribute more to adverse events and to antimicrobial resistance, and isn't likely to improve clinical outcomes compared to monotherapy. So I would lean more towards monotherapy with oral levofloxacin to clear the balance of the 7 days. So in my opinion, B is the correct answer. Let's move to the next question. MOO, who was admitted from the community for an elective total knee replacement surgery at your hospital, develops post-operative complications, which include pneumonia on day 5. She was admitted with community-acquired pneumonia some 2 months prior to this admission and was successfully treated with IV ceftriaxone at a dose of 1 gram alongside IV azithromycin at a daily dose of 500 milligrams infused over an hour. Her pulmonary status deteriorates today and she requires mechanical ventilation for respiratory support. She becomes hemodynamically unstable and the use of vasopressor support appears imminent. Her renal function is normal, and you are asked to recommend initial empiric antibiotic therapy for this patient. In your hospital, piperacillin tazobactam is the treatment of choice for nosocomial pneumonia, and your antibiogram demonstrates 83% susceptibility to it among the respiratory gram-negative pathogens. And they also tell you that there is a 42% rate of MRSA in the hospital. So, which of the following antibiotics would provide the narrowest spectrum of antimicrobial activity that is considered appropriate for empiric use in this patient's case, in the case of MOO? Would it be piperacillin tazobactam alone? Would it be piperacillin tazobactam alongside gentamicin? Would you infuse piperacillin tazobactam over 4 hours plus vancomycin over 1 hour? Or would you administer the piperacillin tazobactam over 4 hours plus gentamicin over half an hour plus vancomycin over an hour? I'll give you 10 seconds to make the correct choice. So in my opinion, choice D would be the most optimal. Answer A, in my opinion, is incorrect. The use of piperacillin tazobactam alone provides an antimicrobial spectrum that is too narrow for this particular patient MOO, according to the current guidelines for the management of adults with nosocomial pneumonia and ventilator-associated pneumonia. Because she currently, because she received, if I remember well, IV antibiotics for a previous admission of a pneumonia, she is at an increased risk of infection with gram-negative bacteria. Now, we know that the Pseudomonas aeruginosa may highly likely infect such patients. At the hospital, 17% of the respiratory gram-negative bacteria pathogens are susceptible to piperacillin tazobactam. And she's also at an increased risk of infection caused by MRSA because of the high rates in the hospital, which exceed the 10% mark. Therefore, dual antibiotic therapy that covers gram-negative coverage, which would in this case be piperacillin tazobactam plus gentamicin, alongside one that covers MRSA, is indicated, such as vancomycin. And this explains why answers A, B, and C are incorrect. D would be the most appropriate answer in this patient's case. So in the next question, TOO is a female with HAP and septic shock that develops 5 days after she undergoes a hip replacement surgery. She received the maximum recommended amount of normal saline for the treatment of her shock. The use of a vasopressor support is eminent because she's not responding to the fluid resuscitation. So which of the following is the next best step in the treatment of her shock, based on the Surviving Sepsis Campaign international guidelines for the management of septic shock? Is it dextrose 5% in water? Is it hydroxyethyl starch, 20% albumin, or IV hydrocortisone? I'll give you 10 seconds to make the correct choice. So in my opinion, albumin would be the best choice. A is incorrect. It is not guideline recommended first choice treatment of shock because dextrose 5% is converted to free water and it may not remain within the intravascular space. Yeah. This patient has already received the maximum recommended amount of crystalloid, and D5 would not add value. Option B appears wrong to me. It is associated with unnecessary risk of kidney injury. It's widely reported in literature, and the guidelines recommend strongly against its use. This is a strong recommendation with high quality evidence. So I would not infuse hydroxyethyl starch in this patient. Now, answer C is correct. Albumin is a guideline recommended choice for the management of sepsis and septic shock. Though the recommendation is weak, the quality of evidence is low, it does work well in such patients. Answer D is incorrect. Now, the addition of 200 milligrams of hydrocortisone is a guideline supported intervention for patients with sepsis and septic shock. However, there is a caveat there. It is indicated only after both fluid resuscitation and vasopressor therapy have been unsuccessful in restoring hemodynamic stability. So it isn't the best choice at this time because our patient has not received any vasopressor support as we speak. So the same patient, you are told the multidisciplinary clinical team asks you to recommend a target blood glucose concentration while she is in septic shock. She doesn't have any history of diabetes mellitus, and your lab has not established her A1C. Her average blood glucose values over the past 72 hours have been 245 milligrams per deciliter. So which of the following is guideline supported upper limit for blood glucose that should be targeted in TOO's case? Is it 110 milligrams per deciliter? Is it 140 milligrams per deciliter? Is it 180 milligrams per deciliter? Or would you tell them that blood glucose need not be corrected in patients without a history of diabetes mellitus? I'll give you 10 seconds to make the correct choice. In my opinion, the correct answer is B. Answer A is incorrect because in the randomized NICE sugar study comparing intensive blood glucose control, which was in the tight range of 81 to 108 milligrams per deciliter, with a less intensive blood glucose target of below 180 milligrams per deciliter in the very critically ill population, there was no significant difference in the 90-day mortality, but the incidence of severe hypoglycemia was significantly higher in that population with intensive blood glucose control, and it was less in the less intensive control group. Therefore, an upper limit of blood glucose of 180 milligrams per deciliter is the best choice for this particular patient. Now, in another landmark randomized study of critically ill patients by Van den Berge and colleagues, a significant reduction in mortality was associated with the intensive insulin therapy, and their target in this case was 80 to 110 milligrams per deciliter compared with conventional treatment with a target of 180 to 200. However, these results have not been replicated, so an upper limit for blood glucose of 110 isn't supported by evidence-based guidelines for critically ill patients at this time. That will make B and A incorrect. Now, answer B to me is incorrect. An upper limit of 140 isn't supported by any large randomized controlled trials, and the risk of hypoglycemia is increased by using this as an upper limit instead of 180. And answer D is incorrect. Blood glucose values should be monitored and corrected in all, and I'll say again, all critically ill patients, regardless of their history of diabetes mail it us. My esteemed and highly treasured and valued listeners and viewers, that brings us to the end of part 12 of our Pharmacotherapy MCQs series. If this video helped you in any way, I would like to humbly urge you to like it and to subscribe to my YouTube channel if you haven't yet done so. I would like to promise you that the best is yet to come, and I'm very thankful for your partnership and your continued support. Thank you for viewing and listening to this video, and I look forward to interacting with you in part 13 of our series. I wish you high impact delivery of pharmacotherapy services as you serve your employer and your esteemed clients. Thank you very much.